Listen, I'm glad that you joined us. Thanks everybody for joining. Folks will be coming in over the next few minutes. I'm seeing some folks on here that haven't talked to in a while. So thanks for spending some time with us. I'm here with my friend Kirk Mack, and I'm gonna do a proper introduction with him here in a bit. But I just want to remind everybody why we're doing practice habits. It's an almost week in, week out effort. The goal is to give back to the practice and to industry, who frankly have mentored and challenged me, where we grew up in South Dakota in the professional practice world. Seems like we had to do a lot for ourselves, and yet we had good mentors and friends who we would reach out to on the coasts or some of the larger cities, and they would share freely, and we just want to do the same. And so, different times of year, we may have, depending on what topics are hot, we may have an industry member come in, we may have a compliance person come in and present a new technology, a new service offering, a doctor, a CFO, or even an executive director from Billings, Montana. Welcome to the podcast, David Kelly. And the the goal is just to learn from one another and share openly and build a community. And it's been fun to see this conversation grow. The whole point of practice habits is that practice would become habit, um, and therefore practice becomes perfect. That's the little play on words. So thanks for joining us. It's a fun conversation today, Kirk, and I created some clickbait with the title, and yet at the same time, I don't know that it is clickbait because the next financial crisis in ophthalmology, while that seems a little far-fetched and is certainly supposed to get folks' attention, you and I see all the time that practices can run aground on in certain categories if they're not careful. And that's what we're going to discuss today. Kirk was one of the very first people that I met in ophthalmology. I had started Advanced Thompson Vision at the very, very tail end of 2003, early 2004, and Kirk was one of the very first vendor partners. I call him partner and friend now, but who called on our practice, and he had questions for me, and I had no idea what you were asking me. I wasn't sure what I didn't know. He was very sure what I didn't know. But I think that between Vance and others, Kirk, we were able to um, make good on what we thought the guest experience should be. And then we
Absolutely.
learned, at least I learned, the business metrics of ophthalmology later on. And that came swimmingly. It's why a lot of folks from Vance Thompson Vision join these calls, is because they've been influential in the success of the program as well and have so much to share. But you've been a good mentor to me over the years. You started, at least when we met, it was when you were with Corcoran Consulting, but before then, you ran a big outfit in Texas. Ophthalmology, multi-specialty. Was it clinic and surgery?
Yeah, I was in actually, it was an academic center. I took care of the Department of Ophthalmology at the University of Texas. So it
Yeah.
was, yeah, it was a little bit of everything. We had residents, fellows, the whole works. So yeah, we saw everything, but that was, gosh, Matt, that was so long ago. I barely
I
remember
know.
that. And now my daughter is a resident at that institution. So evolution, right? Things
Yeah.
change.
Yeah, that's great. Well, listen, like I said, we have learned a lot from you over the years, and you've always steered us straight. Some things were just straight up coding and reimbursement. Some things were the transition from ICD-9 to ICD-10 when we would have a couple of day series for all of our practice on how to do that crosswalk. And then inviting the entirety of the optometric networks to do a similar program. We've been to the war together, and I just share that
Yep.
with everybody because you really want partners like this in the craft who are gonna, there's certain things that I'm gifted at that a lot of people wonder, but that I can contribute, and there's other people who are fascinated by other parts of the business that you should find friendship with so you can tap them when the time comes, and they can fill in where you might not be quite as strong. We call them lesser strengths. So that's just a little bit about you, Kirk. You went from there to Corcoran Consulting, and then were there for many years. Really helped do a ton of the legwork and heavy lifting for that organization. And then recently went to VMG. Before it was BMC, but then sold maybe even a couple of times.
Yeah.
You're a senior consultant there. Um, Give us any more background that we should know before you and I get into some of the brass tacks of what we're faced with in ophthalmology today.
No, I went from Corcoran to BSM. Bruce Maller offered me a position and I couldn't pass it up. And that was 5 years. And then VMG Health picked us up and I don't know, matured a couple of times. So I'm still doing what I've done, working with practices and helping with reimbursement, compliance, and just almost anything in that space. Just now I have a larger team, but they kind of let me stay in my lane of eye care. I don't go out of that. I think either they think I know what I'm doing or I'm too old to learn new things or some combination of both. I'm not sure which. So I'm still in the eye care lane, and that's all I do, and still help practices across the country. Pick a state, I've probably been there to work or help somebody. So yeah, that's what I do, and
Well, and
still
I
doing it.
think I can say this without blowing anyone's cover. You're still very close with my friends, our friends at Vance Thompson Vision, and you happen to be in an airport right now,
Ah,
hopping between one of their institutions or another. And
yes,
so the story continues, right?
absolutely. Yep, I am doing a lot of work for a lot of practices, including some time with the Vance Thompson Group. Absolutely.
Kirk, there's a lot of concern about where revenue is going to come in the future. And um, without getting into too much detail, we can basically say this time of year we get issued these kind of scare tactic statements of all of the cuts that are going to take place in 4.5 months, 5 months. And uh, what's happening here at the federal level?
Well, I mean, the feds put out their proposed rules for physicians and surgery centers slash hospitals. They put those out in July and August. And when you look at the proposed rules, which means there's still a final yet to come, on the physician side, it's not pretty. It's another year of downward adjustments, just an overall adjustment of somewhere between 1.5% and 2% on physician fees. So, I mean, that's pretty significant. There'll be some individual services, codes, surgeries, procedures where it's maybe a little more, a little bit less. But it's too soon to know exactly what those numbers are going to be. But across the board, we're looking at a two-ish, 1.5 to 2%. The proposed rule even put a projection in there of about 3% when they look at all of ophthalmology services. So that's pretty significant. Now, on the facility side, Matt, the ASCs, the rates have gone up for I can't even tell you how many years. Mike Romansky, our friend at US, would say 30 years or something. I don't know. It's a big number, whatever it is. But while that overarching rate went up, we saw an adjustment, unfortunately, to our bread and butter procedure, cataract surgery on the ASC side. But generally, ASCs have gone up for a couple of decades. So it's a mixed bag of things, and it's the clinic that's been suffering because every year we're seeing this trend downward, and it's just starting to pile up, and it's starting to catch up to our partners and our practices and our clients, our friends. Call them what you wish, all of the above.
Yeah, and I'd like to understand, and hopefully you can answer this briefly.
I'll try.
I joke because it's complicated. So I am joking around, but why are we constantly reducing reimbursement?
you know, every I think the one big word is budget neutrality. The government doesn't want to toss any more money in the bucket, and they want it to be budget neutral. Also, if you want to be budget neutral, but you have more people needing those resources because of the Medicare population continues to increase, and in the average ophthalmic practice, that age bracket is a significant portion of our practice. And so we've got, let's just say the bucket is finite, but now we have more people to take care of a year later. So yeah, they've got to make some reductions in individual services, or we don't have enough money to fund the program. So, I mean, that's the simple answer. There's lots more mathematical gymnastics involved, but that's the simplest answer.
Yeah. And when Medicare was created, right, people didn't live quite as long, and yet the most expensive parts of their life are in that last quartile. People, uh, live, on average 20 or so years longer than just a generation ago, two generation and a half ago. That's an
Right.
expensive time in their life.
We had more people paying in as a ratio of how many people were receiving benefits. That ratio is upside down now.
Yeah. And
So
so while we wanted to have budget neutrality when it comes to this category, I don't think we've had that for a long time, though we've had the commitment to have that for a long time. It's not the case, but I don't want to live only with federal reimbursement. By the way, one of the things that I find the most tantalizing in our craft is that if you ask most doctors, even administrators today, what's the biggest threat to ophthalmology, they will say often declining reimbursement. And that uh, that to me, and this is why we're having conversations like this, is extremely short-sighted, right? Because on one hand, it is declining reimbursement for the most commonly performed procedures in the world today, cataract surgery, the most successful procedure, combats the leading cause of blindness, which worldwide is cataracts, and especially in third world countries. And yet, we tout at our national meetings how quick it is, how simple it is. You can go to a booth on the floor, and they can be showing you how quickly they can, be doing a phaco emulsification. They'll have a stopwatch like with a clock up there. And it's like the state record at a cow tying event. I'm just putting that in Billings terms. Montana, great rodeo. But the
yes.
but you see the point where on one hand we're talking about its efficiency, and on the other hand we're bummed out that reimbursement is going down. I think we have to find a way to shift our weight to other revenue sources in the category.
Yeah, and you brought up an interesting point. Sometimes we don't help ourselves by saying how easy something is or how fast something is. I think sometimes that has a negative effect, perhaps. Maybe not. It's hard to correlate that, but let's just talk about access and improving delivery of care versus we can, get a cataract done in 3 minutes or something. So those
Yeah.
things make me nervous. But yes, we have to look beyond just the bread and butter cataract surgery. And, we were very fortunate in eye care in what, early 2000s with the whole uh, two-pronged system where patients were allowed to upgrade. I mean, you remember the first year, we couldn't, we weren't not allowed to offer that benefit to Medicare beneficiaries. It was prohibited that first year or two, and then it got fixed, and we could offer that, and patients could opt for that and make that choice. And
And I
that's
want to just pause there for a second. For those who weren't around at that time, and we talked a lot back then, I almost called you Kevin. Wow. We talked a lot. We talked a lot back then because, if you found out that somebody had Medicare as a payer, it's not like they could just elect to pay the difference. They couldn't. Or they could just elect to not have any reimbursement from Medicare on their cataract. What would happen is if they said yes, and they wanted to have it done, even if they paid the difference, by waiving their right to have Medicare pay, they're actually waiving their Medicare reimbursement for the total hip they might need later in the year. So they were negating their entire healthcare coverage by going off contract, which was terrifying. And so that really needed to be sharpened up, and industry was coming up with all these technologies. But that's why folks at Crystal Lens, and then when Bausch bought bought Ionics, and Andy Corley lobbying and all the things that happened to make that work out is such an important part of our category, because it really opened up the market for people to have the outcomes that they desire.
Yeah, I think if you look at the rest of medicine, they're probably jealous and wish they
Yeah.
had that two-pronged approach that they could offer things like that, but they don't.
Hmm.
Not that I know of anyway. Maybe there is an exception, but I don't know of any. So, yeah, it made a huge shift in ophthalmology and allowed us to withstand some of the adjustments and the cuts and the negative fee schedule adjustments over the years. So, yeah, this was huge, groundbreaking.
Well, I want to talk about that for a second because in other categories, they do try to mimic what we have in the two-prong system. Okay. And we'll get to some other cost constraints that can lead to financial crisis here in a minute. But what I mean by that is having an elective piece, a cash pay piece that lays on top of or just adjacent to your Medicare piece, right? So the
Mhm.
elective portion of an IOL, and I use my hands when I talk about it, I can't help it, from years of just doing the hand jive. On one hand, we've got a medically insurance reimbursable, event with cataract, and then there's all these elective things we can do alongside it to have as good of, refractive outcome as possible. Insurance won't cover this part. And so,
You you need the
one of the
yellow and the
laws,
green, Matt. You need yellow
yeah,
and green
yellow and the
boxes.
green. Yeah, he's referencing our internal forms, but uh it's a no-brainer, but it's worth saying. One of the best ways to combat what's going on with reimbursement declines is to become a better educator on the options that patients have to fine-tune their vision as part of their cataract surgery on the elective side. And what we found, and we found studies that Alcon and others have put out 2 years ago. Alcon did a study of cataract age candidates who were likely to go learn about their options for cataract surgery, who going into it, 51% said that they didn't know that they had any options other than what insurance covered. Now, 2024, it's 20 years, Kirk,
Yeah.
after the very first opportunity to do that. And and we have certainly not saturated the market, even though there's this bell curve of people who know that, this opportunity is coming their way to customize their vision. What do you think's going on there? Why can't we get the message out?
I I do think I do think it's there's a little bit of a dichotomy there, Matt. We have some practices, and you know many as well as I do, that are highly successful at delivering that message and having that conversation and making patients feel comfortable. But we have quite a few more that are not as comfortable. The message is a little bit reluctant. You can pay a little extra, and if that's what you want, but you can get this for free. And there's I think the conversation is very telling in how they formulate that, and I do think that's a big piece of why there's still a big number of practices that have a marginal conversion rate, for lack of a better term. I think that's a part of it. And they're not treating that patient. I'm guessing, this is my guesstimate, is they're not treating that patient in a way that they would want to be treated. Meaning, they are, when they get to that age, they're probably thinking, all right, I'm going to do this, but they're not conveying that same message, would be my guess. So
Yeah, I think that's right. And I think that one of the things that we can say, I mean, there was a conference just this last weekend, an IOL summit, where they were training
mhm.
doctors and team members how to talk about this category, because it continues to be a topic that confounds new practices and existing practices for that matter. But one of the things we heard doctors say, and we hear it all the time, is I didn't go to med school to sell.
Yeah.
Okay. And really important distinction, and because it can feel like that, especially when there's a price tag on it. But a couple things that I use to kind of keep that conversation pure. Number one, and you said it, Kirk, and I'm gonna ding you on it, right? They might not want the cash pay portion when they can have this one over here for free. Is it free? Is
Nothing's
it
free,
is it
Matt.
is it
Nothing.
covered? Right?
Up to a point, yes.
Yeah. So I mean that patients hear covered services and they hear free when we know that there could be co-insurance, deductible, all those different things. And with commercial high deductible plans, these things can be $5,000, $6,000 out of pocket before your coverage actually kicks in. So even the insurance side, if we're not careful, can be cash pay.
Yep.
So the free thing, yeah, I think that words are important. So doctors, if it's just the extra cost that's making them feel like they're selling, then they're selling even on the insurance side of the world, because that's cash pay up until a point. The second part
Yep.
is that if you're just, I really think that if you're just a good educator and you're just providing informed consent, which means you're talking about all the indications of why they need surgery, and then all the options they have to correct that surgery. And by all the options, I mean all the options. If we're just doing that, then I think patients have a fighting chance of making a decision that's best for them. And I don't think that's selling either.
No, patients, the informed consent portion, as you say, if patients know fully what the potential outcome is and what the benefits are, and are given that as a choice, you could see the needle move. I mean, there's always going to be a few patients that are going to pick the most least cost version. I mean, that's we can't avoid that, but having the conversation, providing the adequate education, letting them know all the choices. I think if we don't do that, we're doing them a disservice because their friend across the street went somewhere else and got something and they're elated and happy and they're reading the menu in the restaurant and they're, doing all sorts of things. And the other friend has got the burdens of whatever corrective lenses that are necessary. So giving them that choice is and giving them all the options is, I think, halfway there.
Yeah, and you and I've given talks like this before.
Yeah.
We talked about how there's really two in the premium IOL space, advanced IOLs for cataract surgery. There's two really unhappy patients. Way over on one side is the patient who was promised that they're never going to wear glasses again, right? Overpromised. By the way, there's a lot of great technology out there that can get you close, but
Yep.
we just can't say that in the refractive world. Um, but reduce your dependency, things like that. But let's not overpromise. And then way over here are the people who are just not even given the option, right? They didn't even know it was part of their informed consent. And those we need to be in the middle, well educated, not too promotional, definitely not promissory. And that's a good place to be in the field of medicine. So listen, we can talk all day just about the premium IOL portion, and
Sure.
I love to because we just find it helps so many people. But that's not the only thing driving financial distress right now. And the next thing is everybody who's on this call wants to make more next year than this year, and so do their team members. Right? And by the way, so do the manufacturers who sell them their goods, and so do the service contract, and on and on and on. And we start to add things that we don't, that are really up in the air right now, like tariffs and interest rates, and a lot of these different things. And it can be a little bit of a scary place when it comes to the rising cost of actually delivering the care. What do you see? You getting into, 100 practices a year. How do you see that play out?
Every practice, um, we'll just say taps the brakes when they start looking at acquisitions or bringing on new devices, new technology, new everything. I mean, the bottom line, they're all looking for how do I pay for this? How long will it take me to pay for it? The infamous ROI. I mean, they're looking for that and they're resistant because, as you said, it's not getting cheaper to provide the care. Just the average cost for a cataract procedure is going up, even though the ASC is taking a hit, proposed hit. And they found an error in that calculation last year, but that's a whole different sidebar conversation. But it isn't getting cheaper to deliver medicine. And so we're trying to squeeze out every efficiency, whether that's with new AI things or better technology, but there's still, you have to spend money to do that. And everyone's looking at every nickel now and trying to, make it make sense and to not end up upside down and take on debt. And that's a whole nother problem. And debt's not cheap anymore either. Interest rates are bigger and there's a snowball here.
Yeah, I think this category is among the more frightening for me because it's really difficult to contain the rising cost part. A lot of it is outside the control of the organization, much like the revenue side on reimbursement. It's not like we're going to go to Medicare, make an appeal, and get them to pay us more for the professional side of cataract surgery. Collectively, we may be able to do it through senators, but it's a heavy lift. Um, the On the cost of doing business side, we can try to do just as much with less, or a little bit more with less, or the same. But there will come a time where efficiency can only take us so far. And then we have to find innovative ways to develop cost containment. Any ideas from you on how to contain some of those costs? I don't want to lead you too much. I've got some things to comment on here, but
uh, there's some great technology out there, and I think everyone is looking into the AI periscope, trying to figure out if there's a way to harness that from whatever you're doing, whether that's patient phone calls, whether that's doing some of the redundant works in the administrative billing, revenue cycle management spaces, doing it for insurance prior auths. If you can reduce some of those redundancies and still grow without having to add staff, I mean, that is a great place to look. It's an investment. There's a little bit of a trial and error because these things are changing overnight. But you and I both know everyone's looking at that and trying to harness that. And there's vendors out there, and there's people I know that are doing their own things in Claude and some of these other tools. And I'm just amazed at the progress that we see overnight sometimes. So yeah, I think that's a huge space, and people are trying to harness it.
Yeah, that's exactly where I was hoping you would go. A lot of the big strategics are after this, right? With decision making support, with diagnostics, et cetera.
Mhm.
A lot of them have focused on how to use this for the mundane work at the practice. I work with one who says, we've created a lot of innovation on the actual products we're selling to practices, but we haven't done very much to make it easier to do business for the practice. And that's where they're headed next. And just see here, I've got somebody who I'm going to mute.
I mean, some of these redundant tasks like prior authorizations and adjustments and write-offs and those things that are manpower issues that are really just tedious and over and repetitive. Whatever we can do to mitigate that and use those people for the 20% that needs the human touch, if that function, if 80% of it can be moved into something more automated and we can use that human for the 20%, I mean, that's a win.
Huge win.
Yeah.
So that's one way. By the way, just a APB out for everybody. Anybody who wants to create an AI solution for credentialing a new provider, that's just like right, your golden ticket. That is the worst. And it shouldn't require a human other than the provider themselves.
I- Yeah, I don't want to throw too many people under the bus, but on the other side, when you send in credentialing, there's a human and all kinds of weird things happen. So anyway,
Yeah,
yeah.
yeah. It is not error proof, that's for sure. Okay, so we talk about the rising cost side. I think that's relatively obvious, and there are some ways to combat that, right?
Mhm.
Friends of ours who are in the ophthalmology space, they don't have a commitment to do more with less, but they do have a commitment to do more with the same. And so one way is to just try to outpace your costs with growth, with volume, with looking at new ways to do things, turning that cataract consult from 2.5 hours to 1.5 hours. Maybe finding some vendor support to do education offsite or before or after the visit, rather than that valuable real estate time being taken up, doing things that could be done somewhere else. And I think maybe not this year, maybe not next year, but we're coming towards a time where that will be forced upon us by the sheer volume of patients that are coming through compared to the number of providers we have to service them. So I think that's an important consideration. Because I want to keep us on track, I've only got a couple minutes to talk about this piece, then we'll open it up to our audience here, our listeners. But Kirk, what you and I have observed several rounds of ophthalmology clinics and surgery centers redefining their ownership structure, right? And we're the pendulum has swung all the way one way where a lot of practices are now owned collectively by private equity. And some people took, nice payouts. Some of them took modest payouts and rolled a lot into the new co. Um, but that was done, especially in my opinion, when rates borrowing was preferential because of the low cost of capital, the low cost interest in using debt to do just that. Well, that's shifting, right?
Mhm.
With interest rates holding as high as they are, and they're still nothing like they were in the 80s and early 90s, but they're still high. Certainly higher than some of the investors hoped or planned for them to be when they started purchasing practices. And I think what we're starting to find is there's not as many deals being done. I don't think that's news to anybody, but maybe there's even deals where practices are liquidating. They're being sold off from private equity without naming, any names. What are you seeing in the marketplace? Because you've got a front row seat to
Yeah.
this.
I think there's two observations based on what you've brought up, Matt. Definitely fewer deals. I don't think anybody is unaware of that. And I would say there's more attention spent on those deals, meaning, is this a good deal? Are we getting a good practice? Are we doing our due diligence to investigate that? In the days of what, 18, 19, 20, when the deals were much more frequent and greater, I think some of the due diligence was a little less rigorous, since I was part of some of those. But now I think they're putting a bigger magnifying glass on these deals to make sure everything is, all the ducks are lined up. And the other piece is we're seeing, again, front row, unfortunately, sometimes we're seeing some spinoffs, and maybe it's a practice that's not doing as well, or we're seeing some of these larger groups unloading some practices. And so maybe there's a deal, a dollar amount, or some reduction, or some, bargain basement pricing. I don't know. And stay out of some of those pieces, but we're seeing some of those. And so that's starting to pop up and is becoming part of the marketplace.
Yeah, I think the opportunity is to, put it in short form is while you may have taken a payout for your business a while ago, you might be able to buy it back for a fraction of what they paid.
Right.
That, by the way, that happened before. Again, same time frame as the higher interest rates before, a very similar choreography of a sell out and then purchase back. And so we'll see if that's how this plays out in the future. What I am seeing is these larger groups are trying to deploy everything we just talked about with surgery first, interventional kind of care where perhaps we're helping patients more quickly. Recommending a caseload that perhaps might reimburse at a higher rate. We're trying to teach an organization to do more premium IOLs or at least educate better. And it's fascinating to see the business side of the world really go after these categories in mass.
I think we learned a couple other things too, not just the procedures. And we talk about interventional, and you and I have done a couple courses together, so we've had multiple hours of conversations. But there's so many other pieces around those, and I think of the glaucoma piece because I've done some studies and you've put out some data that just the other pieces that if you manage those patients with a standard of care that's appropriate and best practices, there's opportunities there in diagnostics and evaluations, not just the interventional side. That's, in our observation, is really being missed in many practices. So I think just being attentive to that nuance, I think, helps you be more effective in your own practice. And that's not necessarily just physician work, because some of those things are delegated out to staff and technicians, et cetera. So again, I think that's being more effective and more efficient.
Well, and I'm just going to be super specific. The thing that I want folks to know is, for as much glaucoma as has been diagnosed, our propensity to actually do a relevant amount of visual fields to follow the progressive disease and make sure it's not going running rampant, it frankly isn't standard of care. We should be doing a lot more visual fields than we are for as much glaucoma as we are diagnosing. And so there's standards on this that Academy, and I'm not sure if Askers has or not, but has published on how often is reasonable for these ongoing diagnostics. But these are really good for the patient to monitor a progressive disease that's sight stealing, but it's also reimbursable. And those are the
Yes.
things that we're talking about. Like you've got the patient there, do the work, be complete, like it was your own mother. Now I'm gonna just give you chance to kind of collect your thoughts, Kirk, and have any kind of closing comments. But I do want to share with the team just some things that I think are important tenets when it comes to financials. And I'm not sure that it's still the case, but where I grew up in ophthalmology, we thought a balanced revenue uh, package was having about a third of our revenue come from federal reimbursement, about a third of it coming from commercial, and having about a third of it coming from cash pay or elective services. Now, there's been times when it's been far more on the elective side, and times when it's been, one or the other for different reasons. But I do think that that's a well balanced. For me, what that is it's a litmus test for the health of a practice. that they've got a population that they're serving in the aging population as appropriate, that they've got a good mix of folks who are being communicated with probably through an optometric core that are not Medicare age yet, but have commercial insurance for those kinds of things, and that they've made every effort to make the elective piece kind of the ballast to the organization that makes it so they're not so blown around by the winds of change that come with reimbursement. And so that if you're looking for a target, that's where I'd start. A lot of folks aren't there, and my old alma mater might not be there exactly right now, but it's just it's just a kind of a good way to back of napkin check the health of your organization. I want to open up the lines. You can unmute, and if you've got questions for Kirk on what he's seeing, things to expect, maybe reimbursement wise, as we round out the to the end of the year and plan for 2027. You can go ahead and ask him now. He's not billing for this time, right, Kirk?
Oh, of course, absolutely. This is my give back, my contribution. Pay it forward. I'm always,
It's part of
you,
yeah, it's
you
part of my
know
work
me.
release, and you're donating your time to little old
Well,
me.
it's a supervised work release, right?
That's right. That's right. What questions do you have for Kirk?
Or Matt.
Kirk, I have a question for you. So as you know, kind of the practice manager or the executive director here in Billings, I'm supporting the doctors, I'm supporting the team, I'm supporting the business, and I'm thinking a lot about the operations and the finance of the business and ensuring that we're healthy, primarily through the lens of the patient experience. But I'm curious, we're talking about the next financial crisis. If you were going to give me like the top one or two things that you think that I should focus on to ensure that we're stable, uh, what would you say?
Oh gosh, and you have one of them already, David, in that you have a surgery center, and getting that surgery center up to its most efficient, what its capacity, which I'm guessing there may be a little room there for capacity, but I would say that's probably a really good place to start. And I know that's already on your plate, so I won't beat that up too much. But I think if you've got a facility and those reimbursements are going up, minus the discussion around cataracts, which is still its proposed rule. I think that's a great place to start. The other piece Matt and I talked about is ensuring that your team is well equipped to talk about some of the non-covered upgrades, whether it's that or it's in another category. And then the third piece, we hinted at it right at the very end, David, is making sure you're delivering the standard of care to those patients who might be medical, whether it's commercial or government payers, and providing that standard of care. The example being the glaucoma patients, which again, Matt and I have looked at oodles of those, but I think those are probably three places to start, especially owning an ASC. That one's that's a slam dunk.
I would say something, David, that I've talked to, I think you before, but certainly some of your leadership, which is you heard us talking about the private equity world and how there may be opportunities for providers to either buy their business back or maybe just walk away from the organization without some of the constraints that existed before, non-compete wise or others. Meanwhile, there's been evidence this last few years that some folks, because there was money involved, they do have an enforceable non-compete. Well, I'm thinking of a marketplace like yours. You've got a world-class center, a world-class team. You've got great ODs on staff, and you've got doctors who are coming from a little bit of ways away to do the cases that are there. And you might be booked out farther than you hoped. Where I start to think is, man, is our beautiful town in Montana someplace that a doctor might want to come from Central Florida 1 week a month and just clear the deck on surgery? And then all of a sudden, this amazing business opportunity that I mentioned on how to use AI to do credentialing becomes really, really helpful because you get them credentialed, you get them on plan for insurance. But I think an organization with a good reputation could become a place where people come once a month. Family might want to come with them during the awesome months of the year and work out their non-compete for a weekly salary a month. And I mean, I'm just brainstorming here, but this is the kind of thinking that I think we're going to have to come up with.
Actually, Matt, I know of one relatively young surgeon, younger than me, doing that exact same thing, doing exactly what you just said. He's gone far enough away and he works a week here and then he works another week somewhere else and he's comfortable and happy and enjoying his family and his kids the other 2 weeks of the month and he's living the dream, so to speak.
Well, and so he's doing that long term.
He's going to do it to maybe he likes it,
Yeah,
but
interesting.
for now it is for the duration of his non-compete.
Yeah. Yeah, so I mean, it's an interesting model, right? And
Yeah.
who wouldn't want to have that experience with a practice like yours, David?
Yeah.
Especially as they're contemplating building their own or starting their own again. So I think, again, just at the table, that kind of thinking, no capacity over here, lots of capacity over here. How do we, put these things together? I think just stepping back a little bit and looking at the whole is going to be something we have to do over the next 24 months. What other questions do we have for Kirk or Matt?
Matt, there was one other point we didn't really talk about it is when we visit practices, we still have some of our surgeons doing things that perhaps could be handed off and that we could have them moving on doing something that's a little more productive, for lack of a better term, having a little more time for surgery, a little more time for other things. And I know some of our physicians like to hold on to certain pieces of their practice and the counseling and the education. But I think looking at that as well and how that's being done in your practice is probably worth a few minutes.
Yeah, specializing up, right?
Yep.
Working towards the absolute tip top of your
Yep.
license,
Yep.
both on the optometric side and the surgeon side, is going to
Correct.
become really, really important over the next few years.
There's a supply and demand. We can't let our surgeons counsel our patients on their vision benefits. It's not the best use of their time.
That's right. I was talking to a doctor this morning who is doing all of his pre-education himself, a surgeon. He's calling the patient a week before their exam, talking about their options, and so commendable, right? I
Yes.
love it, and I love that commitment to the patient experience. And yet, I want to say, how about you just add 4 or 5 cases that day because you're booked out. You're booked out a long time, and
Yeah.
maybe your OD can make that call, or
There-
or your administrator, or one of the vendor companies we featured here before.
There's a way to make that warm handoff.
Yep.
Yeah, definitely. Yeah.
Well, listen, everybody, we've spent 3/4 of an hour together, and I love these sessions, Kirk. Provocative. Hopefully, you all gathered something that you can apply back to your practice, even if it is just a provocation, a different way to look at things. We hope that you come back to hear our conversation next week. We have Keely Bover coming, and she's going to talk about the importance of research as the lifeblood of innovation within a clinic. There was a time and place where at Vance Thompson Vision, I actually participated in running the research. It's really good when professionals start to do that work. But she's really turned it into a program that's touched all of the different sites, and also made it so it can be a profitable part of your program while helping a lot of people. So that's going to be next week. We encourage you to come back, and we encourage you to bring your friends. So hopefully through all this, we can come to a place where practice become habit and habits become perfect.
Thank you.
Thanks, Kirk.
Hey, Matt, thanks for the invite. Thanks, everyone.